It's a really important conversation that we need to have. To give some context, about 15 years ago, several mechanisms at the global level really tried to help streamline procurement for TB and other medicines and create a more robust market for quality assured mechanisms. This includes the World Health Organization pre-qualification process, the Global Fund, Global Drug Facility, and we've seen, I think, a lot of progress over the years in building a market for quality assured medicines and for affordable medicines and for having more improved supply chains in countries and more streamlined procurement. Now we're entering an era where countries are assuming more responsibility at the national level for procurement and for financing the TB response, along with other disease areas, but we're mostly concerned about TB here today. And these have a lot of implications for regulatory processes, for quality assurance, and for other aspects of procurement. So what we want to do today is talk about what some of those changes might be, what they might mean for countries, what this might do in terms of the number of manufacturers, the quality of drugs available, the price of drugs, and really think about ways to ensure sustainability of the quality assured markets that we've all been working really hard together to build. So we're very pleased to have our first speaker today, Brenda Waning from the Global Drug Facility. Unfortunately, someone from the Global Fund was not able to attend, so we'll just move into Brenda's presentation, and Wim will read her bio.
Yes, good morning, everybody. My name is Wim van der Velde from the TB Community Advisory Board. It's my pleasure to introduce Brenda Waning, who's going to talk about procurement trends in the RTB medicines market. Brenda is the chief of the Global Drug Facility. She was the coordinator of market dynamics at Unitaid, where she led efforts related to the Unitaid's technical strategy, market assessments, and strategic investments. Prior to joining Unitaid, Brenda served as director of pharmaceutical policy at Boston University School of Medicine. Brenda, you have it.
Thanks, Wim, and thanks, Erica. Thanks, everyone, for joining us this morning. We're really pleased to see you here because we think from the GDF perspective that this is perhaps our most pressing priority and concern as we think about all the changes happening in the global health space over the next 5 to 10 years. So we're very glad that you're here and that we can begin this discussion in the hopes that this is one of many discussions and actions to come. So I'm going to basically just go through an introductory presentation to give you an overview of what we're seeing in procurement at a very informal basis. It's not a systematic assessment, but it's an informal observations. And some warning signs that we're seeing associated with new policies from the Global Fund around co-financing and some experiences with countries who have already transitioned from the Global Fund. So I have no conflict to disclose in this session. The session outline, I have basically 4 different sections, and then some summary and conclusion. So very quickly, I'm just going to give an overview of relevant history and updates with the Global Fund, specifically around how they've looked at market shaping history over time, and then their most recent revision of the sustainability, transition, and co-financing policy. Then I'm going to describe a little bit about what we've seen in terms of evolution of the TB market, mostly really sustained with Global Fund financing. And then we'll get into some observations about what we're seeing around procurement. Then we'll just very briefly discuss in one slide what our plan is in trying to further understand this space, and then some conclusions. So first, with the Global Fund not presenting in the first session, I just added a couple slides I don't have the detailed trends that they may have presented, but just a high-level overview from the Global Fund perspective. So I don't think a lot of people know, but market shaping for the Global Fund was something that the experts who kind of formed the Global Fund explicitly detailed from day one. So from day one of the Global Fund, it was realized that the purchasing power that would be afforded the Global Fund with the amount of money going through and the amount of purchases being made would allow them to do more than just send drugs to countries. And it would allow them to use that purchase power to shape markets to make sure that they're operating more effectively, so that when the Global Fund is gone, those markets are in place and people have continued access to products that are quality assured, affordable, and optimized even after the Global Fund. So it's not something new that came in the past few years. If you look at the very early board documents, it's in there from the very beginning. And a lot of you may also not know that Unitate actually came from the Global Fund. So they were part of the Global Fund, and then at some point they separated. The Global Fund separated and became a Swiss foundation, and Unitate stayed in WHO as a standalone hosted entity. So that Unitate market shaping came from Global Fund origins. And after that, there was really a lot of momentum in the global health community to realize that collectively, all of us in the procurement space and even scale-up work could think about how we do our work that goes beyond just delivering products to countries. And many, many organizations, UNICEF, all kinds of organizations adopted market-shaping approaches as a means to improve access beyond just buying. Within the Global Fund itself, their first market-shaping strategy was really created externally from a market dynamics committee. Then that converted into a market dynamics advisory group, and it's now managed by the Global Fund sourcing department, but for HIV and malaria. And for TB, because GDF does so much buying on behalf of the Global Fund, they've basically asked GDF to manage market shaping for TB products funded by the Global Fund. So together, over the past 10 years in particular, there's been an enormous amount of effort from all kinds of stakeholders to basically build the markets that we have today in the 3 diseases, not for the purpose of building markets and creating business, but because we realize that through optimized markets, that we basically can improve access to quality care. So the new update to the Global Fund Sustainability, Transition, and Co-Financing Policy was put out in 2016, so last year. And what's new is that it now requires all countries to have some type of co-financing, and it's escalated. So you start at some percent, and then you go up over the 3 years. So it's no longer just some countries, it's all countries. And it specifically says that countries have to begin to absorb responsibility for procurement of essential drugs and commodities. Unfortunately, there still isn't any policy, there still isn't any operational guidance on how to actually implement this policy. And we'll talk more about why that's a problem in a few slides. What it doesn't include is an explicit goal to ensure that the markets that have been created, largely with Global Fund money, are sustained. It's not mentioned in the policy, and it's not put out there as an explicit goal. There's not a risk management plan to protect markets and access, and there isn't any M&E plan to monitor what are countries buying, who are they buying it from, what are they paying as countries are asked to co-finance and or transition. Okay, so that's about all I want to say for an overview. In terms, let's just go through very quickly some slides on evolution of the TB medicines market. I think all of you in this room know this area very well, so I'll do this very quickly. This is really just the GDF QA medicines market. So from the GDF side, and I see Andre in the room who knows this history much better than me, he's educated me that basically, for the TB side, the way new quality assured products have always been introduced into the TB market has been through grants. So initially, USAID and Canada grants. Remember, GDF was started before the Global Fund. So USAID gave grants for first-line drugs, quality assured drugs, which allowed GDF to supply them. We've had grants from Canada to introduce to introduce pediatric formulations, grants from Unitaid to introduce second-line drugs and diagnostics, and that was really critical to the product introduction, and then the Global Fund picked up later on sort of the scale-up. And so what has the power of GDF as a pool procurement mechanism done for the market? What we've seen is a dramatic increase in the number of quality assured suppliers and formulations. So this doesn't even go back to the days of 2001 when GDF first started, but this is from 2007 to 2017, the past 10 years. What you see is in 2007 we had 5 quality assured suppliers, and today we have 24. In terms of the number of formulations, just 6 years ago, in 2011, we only had 24 quality assured formulations, and we now have 117. So this is like dramatic growth of the TB medicines market that's happened with a combination of grants that allowed the products to be introduced, and then Global Fund financing to sustainably scale up access to these quality assured products. You've seen these slides before. You could pick any number of regimens, but there's been a dramatic decrease in regimen prices over the time period. It really varies per regimen. I think it can go anywhere from, let's say, 30-something% all the way up to 70-something%. I give an example here of one particular regimen from 2012 to 2016 that has about a 44% price reduction, and another one this is the most expensive regimen with a 45% price reduction. So dramatic increases in the reduction in price. So I'm not going to go over this in particular. This is sort of GDF facts and figures about what we've been able to deliver to date. So on the left-hand side, you see deliveries to date, and on the right-hand side, you see orders to date, because some of them are still in process and haven't been delivered. And this is as of the end of September. But look at the bottom left-hand corner. And what you see there is 57 days lead time for deliveries from SRS in 2017. And I'll mention this later. Many of you don't know that GDF has a strategic rotating stockpile, and that's where we serve most of our orders for second-line drugs. It was funded by Unitaid. They closed the project. We shut it down in 2015, have been returning the money to them, but got additional financing to rebuild a new stockpile. And with that opportunity to rebuild and rethink things, it was dramatically reconfigured. And the orders that are going through that system now are getting there in 57 days. Now that, compared to where GDF started out in terms of 6 months, is pretty impressive. But we can only do that because we have the volumes that allow us to buy drugs ahead of time, put it in a stockpile, assume the risk that they'll be purchased, and provide them to you with short lead times. There's no other way to get those drugs to you that quickly. This one I'm not going to go through. Okay. So that's the good news, but I think we need to keep things into perspective. TB is still a very small market. It's not HIV, it's not malaria. So even though we've seen this dramatic growth, which is fantastic and we're happy, it's still very problematic. And this is basically a summary of annual GDF sales. And what you can see on the first column is, the first 2 columns is the number of products that have annual sales in these different categories. And in the red box I've outlined, you can basically see that 61% of the products that we sell have annual sales less than $1 million. These are tiny, 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 tiny markets that if you don't have a coordinated mechanism to supply them, it gets very difficult to keep these products available for buyers. And as I said before, the stockpile is really what's allowed us to do that. So the stockpile is what we consider our super glue, basically, that really allows us to hold things together, get things there quickly. When Global Fund cancels orders, that's what allows us to more easily reallocate orders to other countries. It's what allows us to serve emergency orders. It's what allows us to support product introduction when countries are ordering 1 or 2, 3 products at a time, treatments. And that's been, I think the best case there is with delaminid. So this is up to September, our procurement update on how much delaminid we've supplied. And you can see in 2016, we delivered 620 treatments. About half of those were to MSF. In the first 3 quarters of 2017, we delivered a little under 1,000, and there's about 3,000 that have been ordered, so some still waiting for delivery. So again, probably you don't know when you order from us what the process is behind the scene, but when we made an agreement with Otsuka, we agreed to put delaminid in the stockpile, even though we didn't have any insight beyond MTB project what the volume would be. So that means that GDF assumed the risk for holding onto this stock and hoping that countries would buy it. What this has allowed us to do is to help countries who are introducing it but are only buying products for 1, 2, 3, 4 patients at a time. And we see a lot of that. It's very common with delaminid that we have order volumes less than 10 treatments. We also have emergency situations. Somebody's pre-XDR, XDR, they want that drug tomorrow. And the SRS allows us to get it there. We all know Otsuka has announced new licenses. It's unclear now, in the context of global fund co-financing, global fund transition, how that, along with the licenses, will impact GDF's ability to provide this level of service that we have been providing in terms of delaminid procurement. We just don't know. We still need to get more details. We still need to understand how countries are going to adopt to the co-financing, but we're quite worried. We are really worried that these companies who got the licenses, are they going to do what GDF does? So if you're a country and you need 4 treatments, is a company going to register the product in your country, adhere to all of your packaging requirements in order to supply 4 treatments at a time? If the licensees get all the volumes from India and the high-burden countries, and GDF is left with just tiny, tiny, tiny volumes, can we continue our SRS? I don't think so. So I think all of these are really complicated questions that a lot of different factors coming together make for a really unclear picture of what the future is going to look like. So what have we seen so far in terms of just general observations from procurement practices as countries begin to co-finance or have already transitioned? This is not systematic. We will be doing a systematic assessment. This is really just anecdotally talking to our regional advisors who are in these countries, consultants from missions, and so on. Oops, sorry. It's not clear where you point this thing. There we go. Okay. So what have we seen? As countries begin to assume their own responsibility for co-financing and they're buying domestically, obviously they then revert from global fund rules around procurement to domestic policies. And that dictates how and what they procure. And so what are some outcomes that we have seen anecdotally from the co-financing experience and the transition experience? We see protracted tendering and contracting processes that go on so long that they end up in medicine stockouts. We see failed tenders because companies aren't going to, for many reasons. Maybe a company doesn't bid because the volumes are so low, maybe products aren't registered, all kinds of reasons. We see delays in the allocation of funding to pay after a tender has been awarded and the drugs are ordered. And that, again, any kinds of delay can result in shortages and stockouts. We see service not at the level we would want to see from the service providers that actually win the tenders and are providing the service. And when we look at how countries choose to buy when they co-finance or when they transition out, what we see is countries popping in and out of the GDF service. And so we've pulled together some examples to show you. So we've taken off the country names, and these are countries with FLDs who have transitioned already or are currently co-financing. It's a mixture. And the red means they did not buy from GDF, and the green means that they did. And we've tried to analyze this to see, are there any trends of who stays, who goes, what is the pattern of coming back and forth? And as you can see, there are no trends. You can't draw any trend lines here. And so really trying to understand what countries do, why they do it, what are the implications, is really, really difficult. This is for FLDs. And then this is the second line drug procurement after countries who have already transitioned, which is why you see so much red. And so this is a lot of countries from this region, actually. But by and large, a lot of countries leave the GDF market. And you can see that over the past couple of years, some of them popping back. They may not be popping back for good. It may just be an emergency, a short-term thing, a gap filler. We really don't know. We only looked at, are they buying, what's the frequency, and we need to understand this more. Okay, if we look at what countries buy, what we see is that country regulations and preferences often result in countries buying locally produced or locally supplied products. And what does that mean? It means not all the time, but with some exception, with a few exceptions, most of the local manufacturers don't meet international quality standards, which means they're not pre-qualified and they're not approved by a strict regulatory authority. So I just learned that with India's co-financing requirements from the Global Fund, that they, even though they have sufficient funding from the Global Fund, they have to co-finance. And that they have chosen to buy non-pre-qualified pediatric first-line drugs. The reason being that there's only one pre-qualified supplier in the country right now, and they have chosen to buy non-pre-qualified SLDs because of price. So this is the kinds of things that you see, and I think we haven't seen the impact of that yet because it's brand new, but India making that decision changes things for all of us, because India is what holds this market together. We see price being the major driving factor in tender award decisions rather than quality or optimized formulations. For example, choosing to buy single products over FTCs. And we're beginning to see countries roll back to using non-WHO recommended regimens. So this is just a schematic that we put together that basically kind of shows at a very visual level what things look like pre-Global Fund, how Global Fund, it's not just Global Fund, but just for simplification, how things changed for the better during Global Fund and our worries during co-financing and transition. So pre-Global Fund for medicines, we had multiple first line, we had multiple tablets, we had injections, we had not optimized, not user-friendly products. Now with all of the work that's been done by many players, but largely because of Global Fund funding, we were able to finally see fixed-dose combinations for TB. It came well after that for HIV, but we finally have them. We see products optimized at least for first line in a user-friendly format. What will things look like post-Global Fund or during co-financing? We don't know, but we're already seeing things in some countries revert back to what we saw pre-Global Fund. Same with quality assurance, which we already talked about. Before Global Fund, no internationally quality assured requirements. With Global Fund, that leverage required it, and now we're seeing things revert back. And then lastly is price. We definitely saw higher prices before the Global Fund. All of us pooling together allowed for prices to decrease, and it's unclear what's going to happen during co-financing and transition. We've already seen even good big buyers end up doing tenders for quality assured medicines that were twice what we paid. So they will not, individual countries with a few exceptions like India will not be able to get the same prices that we've been able to get on behalf of all. Same with diagnostics. So basically, pre-Global Fund, we saw mostly solid culture for TB diagnosis and DST. During the Global Fund, we saw a big move to automated liquid culture. And now we're starting to see a lot of countries decreasing the liquid culture and moving back to solid. Microscopy. This was the standard of care before the Global Fund. During the Global Fund, we were able to see expert released and launched and largely scaled up. Will countries be able to continue to buy cartridges at the rate they have been under Global Fund? It's unclear. And then what countries pay. I'm not going to go into this in detail, but we really don't know what countries are paying for what they're buying when they co-finance or after they've transitioned. But we see increases charged by local suppliers compared to GDF for many reasons that I don't really have time to get into, including for countries who graduate from Global Fund who aren't able to get access pricing for certain products, including Gene Expert. We're seeing prices up to 10 times what was paid under when they were eligible for Global Fund financing. So what's GDF's strategy in trying to better understand and deal with issues around co-financing and transition? Well, our overall goal is basically to ensure that as countries co-finance and transition, that they're able to basically meet the public health goals of providing access to treatment with optimized, affordable, quality-assured products that have been available for the past several years, that are available now. So that's our goal. Now, how that happens, frankly, we don't care. If it's through GDF, great. If it's not, it doesn't matter. The only point is, collectively, the financing situation is changing. That's affecting the market. We need to figure out together how we need to regroup to make sure we don't lose that market. So what are our plans to sort of help reach this goal? First, we need to really better understand the future funding landscape under the new co-financing scheme. This is not an easy task. Why? It's not centralized at the Global Fund. You literally have to go country by country by country and ask, oh, hello, FPM for, no, you've already gone. So hello, FPM for, I don't know, Kyrgyzstan. What is the co-financing requirements for this country over the next 3-year grant? And they might say, oh, 30%, 60%, 90%. That may be all you get from the FPM, because that may be all they know. They may not know if that 30% is being used for drug procurement, what they're buying, where they're buying from, because nobody's looking at that. They're basically just requiring that the government prove that they're spending this money. And it's all at the individual country level. There's no system, there's no centralized mechanism to collect all of this. Similarly, there's no systematic assessment of monitoring procurement practices during co-financing and transition. So we don't know what the problems are, we don't know what the lessons learned, we don't know how to address them. So what we're trying to do is we're going to hire some consultants to really get in, at least in our priority countries, and work on a country-by-country basis and try to understand first what the financing requirements are and then what countries are doing with that. Then we really want to do a real systematic assessment of procurement practices in these countries. Now that we know how much money they're spending, what are they doing with it? We want to be able to identify issues and share lessons learned, and we want to be able to really describe and quantify what is being procured. If we know that when countries co-finance, they move out of the quality assured market, and we know their trajectory for co-financing, we can model what happens to the qualified market volume in 3-5 years' time. And that's what we need to do. We need to figure out ahead of time. When we reach a point where volumes are low, it's difficult to keep the QA market intact as it is now. So we need to get this message out there, and we need to work with partners to develop and implement relevant policies and interventions at both global, specifically Global Fund, and country level. And we need to not just do an assessment, but we need some means to regularly monitor progress And on the GDF side, we will incorporate this work into our regular TA missions, at least in our priority countries, probably in the annual missions too, so that we can have at least some sense of being able to monitor what's happening, issues, and how any interventions might be working. So summary and conclusions. I think the good news is we're sitting here today looking at a very different market and availability of really good products at a reasonable price that we didn't have 10 years ago. And there are many people that are responsible for this. A lot of people were involved, USAID and Canada and UNITAID, and a lot of people to get things started, but the Global Fund is what's sustained it and held it together with long-term sustainable big financing. And again, we don't build markets for the sake of building markets. We build markets because we know that when we have that in place, it makes it easier for countries to access care, to access medicines, to provide quality care. However, despite all of the progress that we've made, the TB markets are at best fragile. They're small, they're fragmented, they're problematic. Many of them are actually failed markets that we're holding together with this super glue. And some of them, there actually isn't a market. Take pediatric MDR TB. This is not a market. This is what economists would call an absence of market. So the likelihood that we would think, oh, let's have a market-shaping policy to sustain the pediatric MDR TB quality assured market, good luck. It's not going to happen. We need to prop that market up. We can't desert that market. There's never going to be any market forces in play that will make those economics work. And there's some markets that just aren't there, that if we care about providing quality care, we have to keep them propped up one way or another. From the GDF side, pooled procurement and the strategic rotating stockpile, these have been our ways for holding this market together and meeting access goals. So they've helped us facilitate price reduction, dramatically lower lead times. They've encouraged the development of optimized formulations. They've allowed us to respond emergently to drugs, to requests. And they've allowed us to support new product introduction for things like bedaquiline and delaminid when countries order 1, 2, 3 treatments at a time. So if we lose the volumes in the pool procurement, it's not clear how long we can maintain SRS, because we can't have the risk of having all those products wasted if they're not purchased. And it's really not clear how long we can keep this QA market together if we don't have a certain minimum volume that we need to understand. So in closing, what I would say is that from day one, the Global Fund committed that they would use their leverage not just to send products to countries, but to create markets that would allow countries to access these products long after the Global Fund is gone. And that the legacy of the Global Fund must be to sustain these quality assured markets that have been built from the billions of dollars that have been invested from so many countries, and that everybody in this room and others have worked to create. And in order to do that, the first step of the Global Fund must be to include market sustainability as a clear goal in their sustainability, co-financing, and transition policy. If it's not a goal, then basically you have a bottom-up approach. You basically have FPMs dictating country by country how countries basically implement that sustainability policy. What we need is a top-down approach that says, in addition to the other things that we're concerned around sustainability, market sustainability is key. That's up here. That dictates how countries choose what to buy. So you don't ask them to buy your most fragile products first. You ask them to buy products that are where the markets are working best, so you don't disrupt the market if they leave. Yeah? And so this is basically, I think, from the GF perspective, where we're going to try to liaise with the Global Fund to get them to start, because we think if it's not a goal, none of your work is going to get there. You need to at least commit to the goal, and then how you implement that policy will be very different if it's not clearly articulated. Thank you very much.
Thanks, Brenda. That was a very stimulating presentation, and I'm sure there are a lot of questions. We're going to have time for questions at the end, and we want to make sure that we leave ample time.
Interest to this particular session and presentation. I'm going to share with you our experience of procurement of first-line and second-line TB drugs under government and global fund resources. And I will construct my presentation in the following way. So I will give you some insights how we do forecasting and what factors we consider usually, including epidemiological trends. I'll talk a little bit about budget takeover plan, which government of Georgia committed under this financing requirements, which was already discussed and communicated with you as a global fund strategy. And I'll talk about the legal environment which allows us to use pool procurement mechanisms for the procurement of drugs under government funding, some key considerations, and the way forward. So I present National Center for Disease Control and Public Health, which is a government entity and implementer agency for the Global Fund projects in Georgia since 2014. There is no conflict of interest to disclose. So about just putting Georgia in a global context, so that's many of you, I'm sure, know that that's a country in Eastern Europe with population 3.47 million. So Georgia, until this year, that was an upper middle income country. So it spends already about 3% of its GDP on the public expenditure on health is about 3% of GDP, and which is not really a big amount, as you understood. And we have a significant burden of tuberculosis. So new cases, what we have reported last year, that's 2,500, about 2,500. So as I said, a few words about epidemiological trend. Like in many other countries in our region, so which is Eastern Europe and Central Asia, so incidence of TB is on decline. However, share of MDR TB in new cases, it's 11.6%, and it's about 38% in retreated cases. So in 2016 data shows that we have the improved trend, but it's not published yet, so I relied on previous data. So to talk about a little bit about care cascade in Georgia, so out of 4,000 estimated cases, 90% notified, and same percentage out of notified cases enrolled in treatment. And in absolute figures, so we have about 200, and not about, but absolute figures, exactly 2,862 successfully treated. However, again, main challenge for country is the high default rate. About 1/3 of patients, they interrupt treatment, and the treatment outcome really not good, what we have for their patient. But again, so that was presented during last 2 days by National TB Center of Georgia, so that we have improvement here also for the 2016. So that's the epidemiological trend, very important for quantification and forecasting. And there are a number of other factors which we usually consider. That's availability of rapid first and second line DST in country, based on which usually treatment regimens are administered. We have error warning system. So that's let's say based on different tools available in country developed Excel-based file using average muscle consumption data, and same data are used for forecasting and quantification. So to avoid overstocks or stockouts, so the frequent orders are used twice in a year, and order placed for 12 months, and we use other system for with lead time 9 months. There are a number of other issues also, especially now. So yeah, so that's outcome of the work done together with National TB Center by NCDC, and the dashboard will summarize all needed data to produce exact number of drugs that we need to procure and place order. And other factors we need to consider, so which came recently, so that relates to new development, namely programmatic introduction of shorter treatment regimen, which we're gonna, it's probably very optimistic projection that by the end of this year we will enroll new patients on this shorter treatment regimen, but by the end of this year definitely guideline will be submitted for approval, and the Global Fund support this National TB Center in this work, and as well as WHO Geneva office. Also, there are a number of ongoing clinical trials with shorter duration of treatment, and definitely those development has its impact on consumption of the second-line drugs. Again, as a risk mitigation strategy, so which we can use, that's the frequent orders and close monitoring of consumption and with early warning system, which used in country. So this relates not just to procurement of the second-line drugs under the Global Fund program, but same is done to make to do forecasting for the first-line drug, which is procured in Georgia under the government funding since 2015. This decision was made back in 2014 by the government of Georgia, and they committed to cover and procure first-line drug starting from 2015, and the second-line drug starting from 2017, covering the partially 25%, and the goal is by 2020 or from 2020 to cover this all expenditure under the government financing. This development is reflected in a national strategic plan which was approved by the government last year, and we are now in 2017, and so far, with crossed fingers, government really fulfills its obligation, and we signed contract a few months ago with GDF under government financing to procure 100% of first-line drugs and 25% of second-line, and under the Global Fund program, 75% of second-line drugs. So how the process is organized in Georgia. So regardless of funding source, whether it is the government financing or the Global Fund resources, so we procure first-line and second-line drugs through GDF. Also, the reimbursement is happening through state treasury, regardless of funding source, and there is no barriers for us to do it. Just to explain a little bit, since NCDC PR of the Global Fund programs in Georgia is state agency, Global Fund transfers money to NCDC's account at the state treasury. So we operate for both under the government program and the Global Fund program through the state treasury, and we make reimbursements through it. So there are legal mechanisms which allows us to have to sign contract directly and negotiate directly with GDF for the first-line drugs and the second-line procurement under the government funding. That's provision in the state law of Georgia on state procurement, which allows the waiver. However, so we need to materialize this waiver under the state law on the state budget, which is annually approved by the parliament, which allows us to gives a waiver for this direct contracting. And also the one more step which is needed to be done, that's a government approval of advance payment, which is requested by GDF under the government financing. Probably this is a topic which we can further discuss with GDF and probably change in the future. So based on our trustful relationship already years now. And also there is a possibility to sign and reimburse contracts in euros and USDs, which is regulated National Bank of Georgia. All these development, once again, are reflected in Sustainability and Transition Plan, which was developed by Georgia last year and approved by CCM in this year. And also this plan provides the schedule of the government takeover, not just for the second-line, first-line drugs, but also for other health products and lab consumables, and it relates equally to HIV program and ARV drugs as well. So as soon as the contract signed and the drugs delivered to our custom service, usually we use a so-called CIP or SIP, we call it like this term. So that's, there is now the role for the Medical Activities Regulation Agency, who is responsible for market authorization and quality control in the country. TB drugs are imported without registration, so that's we have the mechanism, so-called registration waiver, and those drugs are delivered as humanitarian aid. None of the drugs, TB drugs, which is delivered in country are registered except one, you can see it. And there is a discussion at the MARA about fast-tracking registration of WHO pre-qualified products. We hope that we'll have results very soon. And for the quality control, after the quality assured drugs are delivered in the country, services are outsourced and performed by private laboratory, which fulfills, meets most requirements, but not all requirements which is set by the Global Fund or WHO. So now, what were the key considerations? So before government made decision about to use the same pool procurement mechanism for IRV and the same pool procurement but through GDF mechanism for procurement of drugs under the government funding. So that's first of all, so I think that there is no need to explain because it was well articulated in previous presentation, that's the market size. So as I said, that's we're a very small country, and even though the burden of TB in Georgia is high, so in absolute numbers, it's really, really tiny, tiny number. So we don't have anything in our hands really to impact and to have direct negotiation with manufacturers. So purchasing power, so that's really weak in that sense. So again, so the quality assurance and the quality control capacity in the country is weak. So we don't know, we really realize that that will be extremely difficult for Georgia, would be difficult to assure the really good quality of products which will be procured under the government funding. So drug registration system, so we have this provision in a legislation which allows us to import or buy and deliver importation of drugs which are not registered through this humanitarian aid mechanism. And there are the legal provisions that I already described, which allows also to have the go for this direct negotiation with GDF in this case, and for in case of IRV, it's a PPM agent. So we have also, it is important to mention that there was experience gained in our country regarding procurement of vaccines through UNICEF, which also use absolutely the same mechanism to perform this task, and that was really useful experience for us, and it helped us to set the mechanism very quickly. And government readiness to support the decision, which is very important. So it may be in countries at the country level most important probably. I'm proud to say so that Georgia is really, I mean, less corrupted country in the region, so that's well recognized, and transparency consideration is something very important. So we use, even though we use this electronic procurement system in the country since 2011 already, and where you can, anybody, so who is interested in, can track all process, including, I mean, starting from the publishing advertisement, tender documents and specifications, and the bid evaluations until the fulfillment, all obligations through the contract, but because of reasons which was listed in the previous presentation, and I'm not going to list of market size and the quality assurance related stuff, etc. So government decided and supported this idea to go and use this same mechanism using government funding. And efficiency consideration, of course, and it's not no need to really talk about that, how important it is to get this quality assured product in optimal prices, especially for the market, like a small market like Georgia is. And last but not least, so that was critical support we received from the Global Fund and the GDF. And it's not something that this session is organized by GDF, but I really want to thank the GDF staff for flexibility they demonstrated through this process. So we never ever experienced any problem, explanations of what kind of barriers we have, how to really avoid some problems, and we all the time have this really outstanding support. And other partners, so first of all, that's USAID and MSF country office as well, so who were part of discussions, and they really facilitated this process a lot. For the next time, this is my last slide. So I think that, not I think, but there are a number of issues which we prioritize for not just today's presentation, but as a part of our next development. That is how to improve, and there is definitely need to improve in state procurement legislation, which really does not distinguish between the health product procurement and any other good procurement. So which really makes it extremely difficult to put quality consideration over cost and price consideration. So it's possible, but extremely difficult really. And also that's we need to test also to incorporate probably in state procurement legislation some different models which is available right now globally. So the second, and probably to echo previous presentation, its most important part is that we need to be a part of this discussion today and in the future, because it's absolutely critical and essential for Georgia to have the same access after we fully graduate from the Global Fund financing. So otherwise, there will be really, the problems we will experience, like it was listed also, and it's well known for many other countries as well who graduated all of the from the Global Fund financing. And also that we're thinking about improvement of drug registration. So we know that there is we can approach it with this regarding this topic, and who can help and facilitate discussion with manufacturers to register their products in Georgia. Also use this WHO support and fast tracking mechanism of pre-qualified products. And as for this health system strengthening, part of the health system strengthening effort in Georgia, so we need to really improve and develop quality assurance and the quality control capacity in this country. I described the problems we have experienced. Also some improvements need to be done throughout this supply chain management, and we need to streamline e-health module, meaning we have with USAID project support electronic TB module developed and piloted in Georgia, but not really full implemented countrywide. And until now, this very much we rely on paper-based forms, which really, not convenience for the, especially for early warning systems and for the forecasting to be most accurate. So that's all by now what I wanted to communicate with you. And since I have 2 more minutes, I would like to introduce 2 key people who really, do this actual work on what is behind this presentation. That's Georgi Kuchukhidze, who is a program manager from NCDC side, and Nino Lomtadze, who is a program manager from National TB Center side. Thank you.
Thank you very much, Dr. Irma. As Erica said, we will have time for questions at the end. I'd like to now ask the third speaker to come to the front to bring us the perspective from Swaziland. Dr. Wilili Sinkonze. Dr. Wilili has conducted a lot of operational research in the areas of epidemiology and clinical research, and is currently the co-principal investigator for both the nationwide TB prevalence and anti-TB drug resistance survey. So in the interest of time, Dr. Wilili, you have the floor.
Thank you very much. So I always have a little bit of a tiff with the podiums and in these settings. But I always have to wear heels when I'm presenting, and I prefer to wear flats. So my flats are in my bag, and I just have my heels for this presentation. So thank you very much for the invitation to share our experience, and we really appreciate that we are able to share our trials and tribulations as we go through this process as a country, and how best we can learn from other countries who have been successful, and how we are able to learn from each other within the region and outside of the region as well. So I've added diagnostics to this presentation because separating the two is really an injustice to the patients that we are trying to serve. And for that matter, as I continue to talk about procurement of the pharmaceuticals, the transition process for the diagnostics as well is playing a very key role. I have no real or perceived conflicts of interest. So just to share some light on those who do not yet know where Swaziland is, we are not a province of South Africa. It's a country on its own, bordered by South Africa and Mozambique. Although we are no longer considered a high TB burden country by the WHO list of high TB burden countries, we do still remain a high TB HIV burden country. We're making good progress towards addressing the twin epidemics. And I'll also shed some light on how the HIV epidemic has been fueling the TB epidemic over the last 25 years or so. But mainly for the purposes of this presentation is our DRTB prevalence rates. We are currently completing our second drug resistance survey, which is aimed for completion at the end of this year, 2017. But as you can see, the prevalence rates from the previous DRS, which was conducted in 2009, 2010, really placed us at triple the regional average. At 8 and 34%. The regional average for DRTB is at 2 to 3% in new cases and 12 to 13% in previously treated cases within the SADC region. So it really placed a lot of emphasis on us to strengthen PMDT and to address this as a priority for the country. So as you can see, over the years, we've been experiencing a gradual increase in the number of cases that have been notified to the NTP up until 2010. And this is really coinciding with the HIV epidemic, and which has been fueling the TB epidemic over the years. But then as well, you'll see, and I'll present to the next slide, what actually happened in 2011. And since then, over time, we've been seeing this gradual but really steady and quite drastic and alarming decline in cases. And not only is it alarming for the notification of cases to the NTP, are we missing cases, but it also has procurement and quantification challenges, which I'll speak more of as we proceed with the presentation. So due to the ongoing challenges and the increases in cases that we had been seeing over the years, Swaziland declared TB a national emergency on World TB Day 2011. At this stage, HIV had been declared a national emergency 20 years prior. And what this did really for us was to mobilize resources within national level, within the regional level, and also at global level to strengthen our TB laboratory systems, but also to allow for us to have a waiver for drug procurement and to increase the government budgets which had been set aside for TB control, which is now prioritized as the HIV budgets, or for HIV control had been prioritized. Now TB was joining those ranks as well. And this means that governments had committed to procure 100% of the first line drugs and 50% of the second lines. And we'll go into how this had happened and why further into the presentation. So with TB laboratory strengthening came the rollout of Gene Experts. We implemented Gene Expert as the initial diagnostic test for presumptive TB cases in 2012. And since then, although we didn't really see an impact amongst DSTB cases, we saw an increase in the number of in the proportion of bacteriologically confirmed cases. But where we have really seen the most significant impact is in the linkages to care for DRTB patients. And I think this is a real testament to the role of rapid molecular diagnostics that are made available for initiating patients early on the appropriate treatments for those who need it and ensuring that they are all linked to care. So this, I think, has been one of the successes for the TB program when it comes to treatment initiation and linkages to care for DRTB patients against the ongoing backdrop or background of declining cases generally within the country. And of those patients who, looking over time from the 2009 cohorts, as per our 2016 TB annual reports, and those cases that were initiated on treatment in 2013, we're also seeing an increase in our cure rates for DRTB cases. And currently, I think a real success for us is the improvement in our treatment success rates, which is currently at 70%. So this is really has to do with the joint efforts when it comes to addressing DRTB from the clinical angle, as well as the laboratory components and all the other stakeholders who play a role, like the Chief Pharmacist's Office. So it was against this backdrop, I'm not sure if this is clear, but against this backdrop that in 2015, the National TB Control Program then developed our NSP, our National Strategic Plan, in 2014, based on the post-2015 Global TB Strategy, on those pillars, prior to it being renamed as the NTB strategy, which really focused on improving case detection to 80% by 2019. At that stage, in 2013, it was around 45%. We're also looking at improving our treatment success rates to 90% by 2019. We're currently at 83%. But also, most importantly, ensuring that a patient-centered approach was undertaken for those who are most vulnerable to being most affected by TB, which in our case were mainly, and we could only really afford to concentrate at that time on DRTB cases. So ensuring that treatments and support is provided for all DRTB cases, and to reduce the prevalence of MDR-TB to less than 5% as compared to the previous drug resistance survey. And in order for this to be achieved, it really required for us to undertake universal or expand access to DST for both first line and second line. And in 2015, we undertook the process of revising the diagnostic algorithm to ensure that all MTB detected patients on GeneXpert, regardless of their rifampicin resistance status, underwent culture and DST at least for first line. And if they were found to be rifampicin resistant on the GeneXpert machine, they were then underwent both first and second line DST. And this was made possible due to reflex testing from the peripheral laboratories and sending of the second sample to the national level for culture and DST. So this has been the diagnostic algorithm in place since 2015, since towards the end of 2015, and it's still being implemented and strengthened as we speak. It required a lot of resource to be put in place in terms of sample transportation systems, which is not perfect and continues to be a challenge that we're trying to address over time. Our turnaround time for results to clinicians for decision making, and also strengthening of the equipment that was available in terms of the midges, the land probe assays, and the GeneXpert machines that were available at peripheral level, but also at central level. And availability of quality assured reagents for drug susceptibility testing for Cana, Capril, moxethionamide. These are the drugs that have been prioritized by our DRTB clinicians for testing for second-line DST. And I say this it was really resource intensive, and at the time we had just completed our application to the Global Fund for the NFM, which we are currently in the final year of implementing. So a decision was then taken to minimize stock ruptures and interruptions to the availability of the supply chain required to implement this algorithm, to move the TB laboratory strengthening budgets and the resources that would be required to implement this algorithm into the grant, whilst allowing the government to transition some of these to their tendering process, in anticipation that from 2018, we would then be able to transition this budget required to implement this algorithm back to the government's processes. It's not as easy as it seems on paper, and it's an ongoing discussion that we are having with our partners. Sorry, the red isn't coming out clearly, but what I had included here were the bullet points, mainly to say that the implementation of this diagnostic algorithm is really dependent on a smooth transition from donor support to domestic funding. Although most tenders have been awarded for these commodities, the procurements have not yet started through government systems. We're still heavily reliant on the PR for procurements through the Global Fund grants. Government does support for maintenance and the buffer stock, although as we know, their systems are quite slow and not as flexible, so we do have a challenge with turnaround time for maintenance and the availability of buffer stock. And then we also face a challenge when it comes to some procurements, for example, through Cepheid for the GeneXpert cartridges, some suppliers who require upfront payments or bank guarantees, letters of credit, for which governments are unable to provide. So then comes the introduction of a middleman or a local supplier who can provide these commodities to the country without needing the upfront payments. But what then this means for us is we lose the concessional prices, or we lose the access to concessional prices which have been negotiated at global level and have to accommodate for a markup. And currently, as we move towards the government's procurements for GeneXpert cartridges, we're looking at paying $15 to $20 per cartridge compared to the concessional price of $10 USD. And then I think an ongoing discussion is, what does this mean for the introduction of newer diagnostics or newer technologies moving forward as we try to transition, or as we transition out of donor support for the laboratory strengthening components. And then to shed some light on the assumptions and quantifications for TB pharmaceuticals, the medicines used in country are selected based on the guidelines which are an adaptation of the WHO guidelines. There is a national quantification committee of the Ministry of Health with a list of forecasting and supply planning for TB commodities led by the central medical stores together with the NTCP. There's annual forecasting and quarterly supply planning conducted for both DS and DR TB commodities. A 3-year budget and quantification is submitted to the planning and procurement units, and we use the mobility method for forecasting due to the challenges with the quality of the consumption data, which have led us to rely mostly on the mobility method. So this is the budget which has been recently submitted for TB pharmaceutical needs from 2016 up until 2019. And as you can see, the budgets for DR TB is almost 8 times that budgets required for DS. And this is mainly due to target or quantifications being based on program targets. Program targets are based on the need to address the suboptimal case detection rates. So we find that targets are on an upward trend, but what is actually being notified at implementation level is on a downward trend. And this has really created some challenges where we really do require very strong feedback to the CMS and to the Chief Pharmacist's Office when it comes to reasons behind us not utilizing the entire budget which is allocated, and other risk factors contributing to wastage of some of the commodities that are being procured. But what you can see here is already in 2016, the budgets for DR TB medicines had already included the new and repurposed drugs, even though for bedaquiline we were using or accessing the USAID donation program up until the end of next year. We had included and made the decision to safeguard a proportion of that budget for when we transition out. Otherwise, the budgets then will remain lower than what the need would be come 2019. And this has also been inflated by the cost for linezolid and cyclocerin as we move or transition out of GDF procurement to local suppliers or local tendering process. Some of these figures are then inflated beyond the control of the program or the ministry. This is the procurement process that the ministry goes through for donations to the Ministry of Health or procurements through GDF, as well as procurement through governments. When there are changes to our PMDT or pediatric TB guidelines, there's a need for them to be first be included into an essential medicines list, to be included in the quantification which is currently ongoing. Tenders then need to be flighted. Competitive bidders are invited to bid to be allocated awards for the tendering process, and then it's included into the supply plan. And what I've highlighted in red is with both processes, there's always, even with the donation aspects, there's usually a back and forth to ensure that the supply plan is to minimize wastage and to ensure that what is being requested is what is needed by the country and will be utilized by the country. And here is where we also face a lot of challenges with the government process, particularly with the awarding of tenders and the delay with our numbers not being attractive enough to attract really competitive bidders, and the delay in awarding of tenders and some of the prices being inflated beyond what is in the budget or what has been allocated. So, as our program manager always says, the road to success is always under construction, as is the road to success for domestic financing. But it's constantly under construction. It's one that we cannot ignore. We need to keep working towards, together with our partners that we work with in country and our other stakeholders that we currently work with. And I think the main thing that we always need to keep at the forefront of our minds is to ensure quality for our patients, to ensure that they're taking, or that the medication and diagnostics we're using is the best quality that is available. So the process really began in 2014 for us when the government committed to procure 100% of TB, DSTB, and DRTB medicines from 2015. And this was also led by the discussions at the time for counterpart financing, or the need to demonstrate counterpart financing and willingness to pay in order for us to have a successful application to the next round of funding through the Global Fund. So that push was also really needed to ensure that the remaining 50% for the DRTB medicines was also transitioned to the government's or domestic financing. And then in 2015, we received a waiver for the new and repurposed drugs, and a waiver as well to procure delaminate through the Global Fund grants. And at the same time, we realized that we're facing many challenges with the second-line drugs, frequent stock ruptures, due to our small numbers when it came to DRTB patients. We were unable to attract really competitive bidders for the tenders that had been flighted. So we then received a waiver as well to move some of these drugs to the TB grants and to procure them through GDF, which has really helped to ensure an uninterrupted supply chain available, although there are still challenges there as well, mainly to do with the pipeline from our end. And then in 2016, the new and repurposed drugs were included in the EML and the tender list. And earlier this year, towards the end of last year, we then received the new allocation for the next round of funding, which has really led to a lot of discussions around sustainability. Our funding allocation had been decreased by 50%. And really the discussion now is transition of the TB laboratory budgets, which cannot be sustained by the current TB grants. And over the next 6 months, this is really the priority, which requires the same level of political will and commitments as was provided for the procurement of TB pharmaceuticals. I think generally it's easier to be passionate.
Sorry, we need you to wrap up so we have time for Q&A. Sorry.
Okay, this is the last slide. So, just some of the challenges to maintaining an uninterrupted supply chain is alignment of financing and procurement processes. For small countries with small numbers who are unable to maintain bidding power and attract attractive competitive bidders, resulting in a delay in awarding of tenders. When it comes to the laboratory capacity for quantification, there's really a need for strengthening there. And it's really good to see that GDF has a diagnostics unit as well, which is concentrating on this. The reduction in availability of funding at both domestic and global level is something that countries also need to take into account. But it's not all doom and gloom, as we do have or establish a National Quantification Committee and a National Supply Chain Management TWG, which is overseeing all these processes. So just to say thank you for listening to us, and mainly thank you to the partners who have been supporting Swaziland in ensuring that we are able to provide all the medication and diagnostics required for TB case detection and therapy in the country.
I'm going to try to cut this short because we're short on time. I'm going to focus in part on what we have found in terms of transition and co-financing planning. Can you all hear me okay? In Eastern Europe and Central Asia, just based on 6 countries, and then give overall recommendations as well as concerns. So just first off, to put it in context, so the region has the fastest growing HIV epidemic, and the Global Fund does not consider incidence and changes in disease trends when determining eligibility. This region also has 9 out of the 16 MDR-TB high-burden countries. It is facing 40% cuts, reductions in funding in the current allocation period. And this is already on top of the previous cuts from 15%. Now, the medical context, and you know it, you heard from Swaziland the importance of gene expert, rapid molecular testing. That is not at every district level in this area, or in countries that are transitioning. We don't have direct-acting antivirals in some of these countries that can cure Hep C to better double cure rates than we have with standard treatment. And not to mention drug-resistant TB drugs, including the newer delaminate and bedaquiline. So that is the context. And one thing we're questioning is whether the Global Fund, in particular, has thought through not only the procurement impact on the market, but also the health impact, given the fact that these innovations have not been consolidated yet into the national HIV, TB, and Hep C programs. So I'll be focusing on TB. At MSF, we work in 8 countries in the region. So this is what we looked at, and you already heard a bit from Georgia in terms of their plans. So we looked at the investment guidance from the Global Fund. So that were the markers that the Global Fund put out in terms of advice for countries on what percentage of co-financing they should hit for second-line TB drugs. And then we also looked at countries' concept notes that had the expressed willingness, the expressed objective of countries
to reach a certain co-financing. Now, just because something was in the concept note doesn't mean that it actually happened. And you see there's some discrepancy with what Georgia has presented in terms of the actual work that has gone on versus what was in the concept note. So here's what we found. Now, this is broken out not by disease burden, mind you, but only by income. So of the lower middle income countries, Kyrgyzstan and Tajikistan are expected to hit 50% co-financing of second-line drugs by the end of the allocation period. For the upper lower middle income countries, including Armenia and Ukraine, that's 75%. And then upper middle income countries, Belarus and Georgia, 100%, and they are to transition at the end of the period. So you've heard already the concerns in terms of the rush to transition without thinking through the potential impact could negatively affect affordability, quality, and accessibility of TB drugs, second line in particular. So we have been asking the Global Fund to carry out or have carried out an independent risk assessment. We've been asking this for more than a year now. So, and to identify the gaps and to provide technical assistance and fund technical assistance or whatever measures are needed so that as the Global Fund steps down, countries can step up, both in terms of TB policies and in terms of strengthening their procurement system. Now, there are many considerations. You've already heard about some of these. So I just want to raise the cost difference. So once Armenia, once Georgia, once Belarus and Armenia transition, what will be the price that they are offered from Otsuka now that countries that have transitioned won't be eligible for the GDF $1,700 for 6-month treatment? I have no idea. Does anyone in this room have any idea? The other issue, and this is what Brenda raised, is the impact of splitting the market. You heard about the large India market, but there are also other concerns, both from the countryside and then what GDF is able to successfully negotiate for. Can GDF compete in national tenders? Now, you heard from Georgia that they are able to procure through GDF, but some countries outside of ICA, within ICA, will have to change their national legislation, their national tendering process, in order to apply to GDF as part of their national procurement system. Also, you heard about the risk of national tenders due to unattractive markets. Now, also the blanket waiver that Global Fund-supported drugs receive, considering the unregistered drugs. This is especially important for second-line drugs. So what will happen once we have the co-financing and transition cliff? There also, as part of the risk assessment, there needs to be consideration of historical issues. Now, you heard from Georgia, they don't have the type of level of corruption as other countries. So as long as there is a perverse incentive to procure the most expensive drug in order to enjoy any kickbacks along the way, then we have a problem. At least there needs to be a consideration. Is that a historical problem that is in place now? Is there transparency of the national tendering process? Is there built-in a local production preference, which is okay, but do these local products stand up to the optimal regimens now? We know that in some cases, a country that is looking at local first-line drugs might have to switch to single dose as opposed to fixed dose. Now let's talk about local production. So of course there's a tension between wanting to support national industry, wanting to invest national capital in national industry. But that tension is in terms of you lose the economies of scale, of course. There's also an issue and a bit of a concern about repackaged drugs. So simply getting drugs from India, for example, and having them repackaged. Are countries able to use TRIPS flexibilities? Are countries able to enable generic competition? So any risk assessment needs to include whether the countries that are co-financing and transitioning, and I don't just mean in Eastern Europe, these are all global recommendations. What are the patentability standards? Do they allow for patent oppositions? Do they allow for parallel importation? These are all strategies that are meant to keep medicines affordable. And these are all WTO sanctioned strategies, but not all governments have these in their national frameworks. On the other end, there are TRIPS Plus provisions, those intellectual property provisions that go beyond what is accepted in terms of protecting public health. Now, you already know the example of ARV, so I'm not going to go through that in terms of the benefit of generic competition. We also need to have any risk assessment, assess, and then also have a concerted effort to address regulatory barriers. So many countries that we looked at as part of an out-of-step report looking at 29 countries do have import waivers that they provide in lieu of registration. And we saw this with bedaquiline and delamanid. So it's great, 89% of 29 countries. Some also have some flexibilities in terms of drug shortages. Some countries that we looked at, quite a number in fact, have a fast-track registration to allow for more competition to national tenders. All of these things matter. Only 41% of the countries that we looked at are enrolled in the WHO collaborative registration procedure. This enables for faster registration using the dossier from WHO pre-qualification program. Another mitigative strategy is to strengthen negotiation, and here I'd like to talk about transparency. So to drug companies, to Janssen, to Otsuka, to those that have products in the pipeline, we need transparency. We need a commitment to transparency. What are the terms of the voluntary licensing? What are the prices being offered across countries in and out of the Global Fund eligibility? What are your plans for the future? Where will you be registering the product? Because you know it has taken way too long to have these drugs registered, especially the newer DRTB drugs. So at least there's a Mylan deal, there's an R-Farm deal to start registering the delamanid product, but we still don't know the price that these drugs will be offered. And we cannot just refer to a press release that came out in February for answers. Also, governments need to have a commitment to transparency, and many of the governments don't. So here we're going, as Brenda mentioned, from quality assuredness and as well as transparency and economies of scale into a bit of a different world. And I don't mean to criticize national procurement systems, but I do think that there should be a commitment to transparency. I also think civil society needs to be supported to watchdog the role. And as much as I've been talking about risk assessment, we need to look back. Now, when Global Fund transitioned, Estonia transitioned and turned off the tap for Panama and for a number of countries. It took too many years to look back and to do an assessment, a case study in terms of what was the impact. And they found the impact, HIV incidence went up, there were quite a few resupply structures. We do not want to force a crisis. We want the Global Fund to be well informed and not have their eyes wide shut in terms of dictating the co-financing terms in the transition issues. Finally, another mitigating strategy in terms of what we expect will be quite high prices is pooled procurement. Now, not all national systems allow for regional or pooled procurement or even having joint negotiations. Also, some countries, obviously Georgia does, can explore whether to continue to use international mechanisms. Again, some might have to change their legislation. Now, I do think that there is an inherent conflict of interest. Oh, by the way, I forgot to mention I don't have one, but the Global Fund does have one, which is they're transitioning countries, they're starting early co-financing, they're rushing into it, but at the same time they're offering a solution, which is their proprietary e-marketplace, because they want to be the Amazon for medical products. Great, be the Amazon for medical products, but don't you see a conflict of interest inherent in that process? Finally, given the context where we have so many countries that have not scaled up DRTB, is this really the time to make it that much harder for countries to procure quality assured, affordable medicines, including the latest second-line drugs? Thank you very much.
Thanks so much, Sharon Ann, for that cogent presentation and for helping us recoup a little time. We're almost at the time, but I think we can probably stay in the room for another 5 or 10 minutes or so for questions if people are able to stay on. So Ramon has a mic if there are any questions.
Yeah, it's working. Okay. Is it on? Okay.
Andrzej Zagorski, MSH. I don't know, it's a question or a comment or a reflection. It's very interesting session. I just wish that it doesn't stay, this discussion doesn't stay within these walls, that it's taken out to Global Fund, and I look with hope at women, Erica. They're very active in promoting good ideas. It must be heard, you know. I'm also thinking, because I was at several meetings with TB Alliance, and looking back at how this fragile market is being shaken also by new regimens, new guidelines, and just recently the advent of shorter regimen. Actually, it's not yet felt, but it will be felt, significant impact on the market. Now we are expecting completely new regimens with new medicines, and if they're packed as FDCs, we're talking of very few products that will be coming from very specific suppliers, and we still need some old medicines for conditions that cannot be treated with these new medicines. We don't know prices, we don't know how much it will cost, but we should start somehow preparing for this. And I just wondered, you know, I think GDF should be really, really involved at the very early stage, like right now. And unfortunately, I didn't see GDF at these meetings with TB Alliance. I believe you should be there. And then another just reflection. I probably misformulated it this morning. WHO, not WHO that, not TB WHO, but WHO that deals with essential medicines. They have developed a lot of guidelines in 80s, 90s for like procurement guidelines, all model documents, etc. And kind of stopped there. What is missing is really good, energetic, aggressive WHO guideline on the introduction of new products. How to bring new products, not just TB, how to bring these new products to vulnerable populations that need them most, given that these populations may be very, very small, that there will be no real market. So I think WHO should be really stirred, pushed to start thinking, or maybe this work is already ongoing. Thank you.
Any other questions or comments? I'll take advantage of the privilege of having the mic. I have a question. I guess it's maybe for Brenda or Sharon Ann. I think we heard really nice examples from Georgia and Swaziland of how to successfully plan for a transition, whereas we've seen a lot of countries are just kind of, it's not really a transition, they're just falling off. And I think, you know, what happened with China is an example of that. There was really not a transition plan in place, and they're hardly treating MDR-TB, let alone using quality medicines to do so now. I was just curious, you know, Georgia and Swaziland are both small countries which face a lot of challenges, but they also in some ways have the benefit of not having local manufacturers, as far as I know, that would really be pushing countries to keep procurement domestic. And I was wondering if you guys have examples of a larger country that is thinking about transition and trying to do things in the kind of way that Georgia and Swaziland have, and are there any, you know, nascent success stories of bigger countries doing this that we could help support or promote?